Hi, this is Brian Wormers recording a lecture on care of the patients with thyroid and parathyroid problems for medical surgical nursing at the University of Sioux Falls. Some of our learning objectives with this will be comparing clinical manifestations of hyperthyroidism with those of hypothyroidism. Look at nursing priorities for patients with thyroid storm and mixed edema coma. We'll look at identifying nursing interventions and collaborative care for patients with thyroid problems. We'll talk about identifying teaching priorities for the patient taking thyroid hormone replacement, and compare clinical manifestations of hypoparathyroidism. So just as a reminder, so you've got a great big chain here. So your hypothalamus, and you've got lots of regulation here going back and forth within these channels. So thyroid releasing hormone, thyroid stimulating hormone all impact the thyroid gland. And then it releases your thyroid hormone of T3, T4, and that can cause increased metabolism. So hyperthyroidism is excessive thyroid hormones that increase the body and ramp it up metabolically. Most common cause is Graves' disease, which is an autoimmune type of a situation. So what you're going to see with this is unplanned weight loss, heat intolerance and sweating, palpitations, increased heart rate, dyspnea, exophthalmosis, or blurring or double vision, which you can see in this image right here, and then a history of previous thyroid surgery or radiation. So objectives, what we might see is that exophthalmosis and impaired vision, size and symmetry of that thyroid gland, so you might see some goiter, increased blood pressure, tachycardia, or dysrhythmias. Their hair is going to change to be finer, softer, and silkier. Their skin might be more warm and you might see an increased metabolic rate with that. Muscle weakness, hyperactive, DTRs, and they might be anxious with this. So with this, you're going to check labs, specifically for your TSH, T3, T4. You're going to look for any antibodies for TSH to diagnose Graves' disease. You might do a thyroid scan with this radioactive iodine because that gets uptaken in the thyroid. Remember, you need that iodine. That's why we add it to salt in this country, because you need the iodine to prevent goiter. And you might do ultrasonography to try and look at that tissue. Nursing priorities, so risk for ineffective breathing pattern, cardiovascular function, ineffective temperature regulation, and anxiety are all key factors for this. Non-surgical management include monitoring their vital signs. Watch for that temperature because that could indicate a thyroid storm, and that could be an emergency situation that we're not going to cover in much detail here. Want to reduce stimulation, promote comfort, and then of course we're given the medications that will help them out. Beta blockers can be used with this one to try and calm that body down a little bit. Radioactive iodine, number one, you can look at that and how it's uptake. The other thing is you can make it radioactive on this iodine, and when it does get reuptake, then the radioactive material might destroy some of those cells. And so this would be a way to destroy some of those cells without actually doing surgery to do it. Bad thing is do not do this in pregnant women because it will knock out, or potentially could knock out, the fetus's thyroid cells as well. And so we want to make sure that they're not pregnant. So planning and implementation, so surgically or the radioactive iodine. So those might be situations that we'll do. So with that, pre-op, try and treat that as much as possible before we do these things, but if that's not possible, then we're doing surgical methods for this to remove the tissue that's causing complications and spare the good tissue. Post-op, comfort, respiratory hypercalcemia, hemorrhage, and respiratory distress are all things that we're watching for and trying to prevent. And then, of course, monitoring for that thyroid storm. Now, if they have a thyroid storm, this can be very scary, but we want to maintain the airway and ventilation. We can give some anti-thyroid, as prescribed. Beta blockers might help with this, steroids might help, and monitor, of course, vitals, EKG rhythm, fluid balances. And then as they're storming, the temperature spikes up, and so cooling measures might be appropriate. Now the opposite of that is hypothyroidism, and so everything slows down. And so this could be an autoimmune type of situation with Hashimoto's, and that results in thyroid complications. This could be the result of thyroid surgery or secondary radioactive iodine treatment. So we just talked about that stuff, but realize that once we treat with that, we might knock them into a hypothyroidism state, and then of course have to treat them with that. This can lead into being way too low on that and causing myxedema coma. And so what you might see with myxedema and hypothyroidism is, dry, coarse hair, lateral thin eyebrows, periorbital edema, dry skin, and then facial puffiness, or kind of a mask is what I've heard it called sometimes. So subjectively, they'll say that they are just really tired, they're weak, they want to sleep more. Everything in their body is slowed down, including their GI tract. They don't have the metabolic rates anymore, so they've got a cold intolerance. You can ask them about any history of hyperthyroidism, drug history, surgical history. All those things are appropriate. What will we see? The edema, muscle movements are slow, heart rate, respiratory rates are slow, temp is decreased, weight is increased. They might have goiter related to iodine deficiency, depression, lethargic, and like I said before, that hair is dry, coarse, and kind of scratchy sometimes. Diagnostic-wise, we're doing levels for TSH, T3, and T4. Nursing priorities is providing oxygenation and monitoring the airway, of course, related to muscle weakness and fatigue. If they have hypotension, we want to treat that appropriately. And then they could have some altered cognitive function related to both of these. So then we want to treat what's causing this, and then maintain cognitive functioning. Planning and implementation. So looking at the respiratory function once again, watching their respiratory rate and depth, monitoring O2 sats, watch breath sounds, and listen to breath sounds, and then maybe even providing ventilator support. Now we do want to monitor for cardiovascular function and tissue perfusion and make sure that it's adequate both for heart rate, blood pressure, and rhythms. So they might get shocky on you, and so you got to watch for decreased urinary output or changes in level of consciousness. So within this, realize that if they are hyperthyroidism, they might be on lifelong hormone replacement with levothyroxine. So other things we want to do, maintain that balance of cognitive function, observe for any changes to that. If the patient goes into a myxedema coma, some of the things that we want to watch and care for is maintain a patent airway, replace IV fluids, give the levothyroxine as prescribed, provide glucose, monitor temperature, blood pressure frequently, cover with warm blankets, and monitor for changes in mental status. Patient teaching wise, well, anytime we're giving meds and hormone replacements, we should tell them about what it is, what it's doing, and side effects. They will need lifelong drugs for this, that they should probably have an alert bracelet on or a necklace. When they should seek care, don't take any over-the-counter drugs that the prescribers are not aware of, because it might interact with some of these other ones. And then have a good diet with lots of fiber and lots of fluids, trying to prevent constipation. So hypo or hyperparathyroidism. So you can kind of see the fun changes here. And so your parathyroid glands get signals from parathyroid hormone and calcium absorption and all these kind of fun things. And you get positive and negative feedback loops on all of these. So remember that the signs and symptoms can mimic hypo or hypercalcemia. And so remember those checks for that for Chvostek's and Trousseau's. You might have some mild tingling, numbness through the muscles, and muscle tetany with this. So that's if it's low. If it's too high, you can get constipation, GI upset, fatigue, lethargy, confusion, coma, death, polyuria, and anorexia. Interventions for this. So if they are high, so we can give diuretics and hydration therapies related to this, monitor cardiac function, prevent any injuries with fractures related to the vitamin D and calcium shifts. Might give oral phosphates and calcitonin, trying to supplement these. And then what we could do too is do surgery on this and remove it if it's causing complications. Now, if they're low on this, of course, we're going to give replacements and monitor calcemia, vitamin D, and magnesium, because they all have an interaction there. That concludes this lecture on thyroid and parathyroid. If you have any questions, feel free to contact me.